Okay. So severe sepsis and sepsis shock. Okay. So this is the one I said that doesn't necessarily happen so quickly, right? Because the patients have to have some type of infection, inflammatory response first. Okay. So treating the infection and the underlying cause of the infection is so important. Matching the bug with the drug. And I'm sure Mrs. Phillips talked to you guys about that when she like recorded her lecture for you. Okay. So WBC is greater than 12,000 or WBC is less than 4,000. Why WBC is less than 4,000? What are we thinking? Viral, right? You guys seen COVID patients, they were coming in, their WBCs were low, unless they had a compounding infection, which they had like a pneumonia or something on top of it. Okay. And then all critically ill patients are at risk. Why? They're stressed, the blood sugar's up, we have invasive devices, right? We're putting an airway into a sterile environment. We're putting a urinary catheter into a sterile environment. We're putting IVs into sterile environments. So we are contaminating the patients. Or if they're not getting up and moving around, they're getting pneumonia or getting bowel obstructions, or we see that the bacteria from the bowel leaving the bowel, and then these patients are ending up infectious. And then of course, like we're one of the #1 problems in the ICU. And who was I in the room with? Oh, I think it was me. I think it was Caitlin and I. We were doing something with the patient. I don't know if it was your, and I was like, we were doing something with the patient. And I was like, oh my gosh, we got to change our gloves because now we're going to go give something IV. And I'm like, I always have to think about that because, you know, once you're gloved, and I feel like we were all guilty of it, especially in COVID, because everybody was in isolation all the time. And you'd be in the room sometimes for like 3 hours straight. And I'm like, oh my gosh, I got to change my gloves. I got to change my gloves. But if I literally just emptied the urinary catheter, even though urine is supposed to be sterile, if it's been sitting in that bag, which it's not sterile, and now I do that, and now I go touch the patient's IV, whatever infection they had in the urine, I've just exposed that IV catheter. You know, same thing. If you see somebody that has a bloodborne pathogen like E. coli, where's the only place we find E. coli? In this bowel or the stool, right? So that means that either we've exposed them through an IV or something else gross. Okay. We don't have to talk about it. Okay. So microorganisms enter the body and we have a failure. We have a system of activation and then metabolic alterations. So this is, you guys can read over this. This is like the whole, you know, it's a form of distributive shock, right? So we're going to see a decreased preload, a decreased afterload, a decreased cardiac output, decreased cardiac index, decreased MAP, decreased stroke volume, right? But the big thing is these patients vasodilate and everything leaks. Think about your septic patients, maybe you've taken care of in the ICU. The fluid starts to leak, they're puffy, right? It starts to leak. We have all this fluid that leaks out of the vascular space, but that compromises our perfusion and our oxygenation, right? Okay. Again, this is patho. Usually one organ dysfunction, but it depends on where the infection's at. So are we in respiratory failure? Maybe. Are we in heart failure? Are we in renal failure? And then what are we treating? So I hope at this point, you guys have spent enough time with us on clinical to say, like, no longer are we just saying, I'm giving you an antibiotic. That's not good enough, right? Poor Bailey was like, get away from me. I was like, what are we giving that antibiotic for? Pull up the cultures, match the bug with the drug. Is it effective? And when we were rounding on Amber's patient, what did they say? They're like, why do we need, we gave this broad spectrum antibiotic for this long because we were worried the patient has this, but guess what? The WBCs are okay. There's no signs. We were given vancomycin. And they're like, there's no signs that this patient has a gram-positive MRSA. So why are we still giving it? We're going to shut down the kidneys like that, right? Vancomycin will shut down the kidneys. It's ototoxic. They can have Redmond syndrome if they get it too fast. So why are we giving them a drug? So they stopped 2 out of 3 antimicrobials because we sat there and had a conversation about the bugs and the drugs. So no longer, ever again, as a nurse, will you guys be like, oh, they're getting an antibiotic. That's not good enough. It's not good enough. Yes. No, it's so in the hospital, we start these broad spectrum antibiotics because we suspect an infection, right? These patients come in, their cardiac output's low, they have a temperature, they're tachycardic. We start culturing everything, and we're not gonna be like, in 3 days, we're gonna treat you once we find out the source of infection. No, what do you guys do in the ER? We're like culturing, like culture everything, right? Urine, face, whatever. You know, you got something draining, get a culture swab. Send it, and then we start a broad spectrum antibiotic right away. Well, then we get those culture results back. We don't need to keep them on those drugs if what we weren't using it to actually treat something. Correct, because it's not actually treating the correct infection. So if you are giving an antibiotic, actually the research says if we're giving antimicrobials and we're trying to treat something that doesn't exist, we are creating the superbugs. So the sooner we stop them, the better off it is. But if we find out that the patient has C. diff and we start them on Flagyl, then we need to make sure that they finish that because they will become resistant to that antimicrobial. But if they were on vancomycin IV because we weren't sure what was going on, and then we figured, let's stop the vanc IV, that's not going to help them. They need to be on the Flagyl for the C. diff once we find the source of infection. So in her patient, they were like, well, wait, they don't need the doxy anymore. They don't need the vancomycin anymore. They're on this cephalosporin, which is treating this infection. That's all they need. Stop everything else. So, you know, we have to think like that. You know, when you get the culture and sensitivity back, do they need to be on 4 antimicrobials? No, you know, maybe initially because their WBCs were 35,000 and we're like, oh, that ain't good, you know. Okay. So massive vasodilatation, of course, it's a pipe problem. Vasodilatation, it's distributive shock, right? So we have a decreased venous return, which means we have a decreased preload. So our CVP, right atrial pressure, our wedge pressure are down. And remember when I tutored you guys, because I didn't teach hemodynamics, when I tutor, I was like, nobody's like, oh, my wedge is really high, but my CVP is really low. Because they're both indicators of volume and preload, right? So if the CVP goes up, the wedge is going up. If the CVP goes down, the wedge is going down, right? You guys remember that? Okay. And if everyone's like hot or it's like, okay. Good. Do you have a question? Oh, okay. So after load, because of vasodilatation, they end up hypotensive and they ended up in septic shock. Let's see. So initially, and this is why I talk about, septic shock as being a slower type of shock. Because you know how we talk about those phases where we have the initial phase, the compensatory phase, the progressive phase, and then the refractory phase. So if you have somebody in anaphylactic shock, they're like initial, compensatory, progressive, it's bad, right? But guess what actually happens in those phases? So the initial phase, oh my gosh, let's think about anaphylactic shock, okay? The initial phase, oh, we've got the insult. So we've got the cardiac output and cardiac index drop a little bit, or the heart rate and the blood pressure drop a little bit. And then instantly, our first responders, our compensatory mechanisms, they start. So instantly, they have it. By the time those patients get to the hospital, compensatory mechanisms have already failed. That is how fast they go through the cycle of anaphylactic shock. So they go through that cycle, but by the time we see them, they're in that progressive phase where we have to save their life or they're going to die, because anaphylactic shock is typically pretty fast. In septic shock, no one's like, oh, I stepped on a nail and 2 hours later I'm in septic shock, right? They get this systemic inflammatory response. They end up septic, they start with this infection, inflammatory response, septic, and then they end up in shock and septic shock. So initially you will see their cardiac output and their cardiac index be normal in septic shock. It will be normal initially until the sepsis progresses, because there's still not compensatory mechanism. So that initial not compensatory mechanism or stage, not mechanism, is pushed out over longer. So we actually see it as nurses, where sometimes in the other shocks, like cardiogenic shock, we don't see it that long. The cardiac output and index is maybe okay for a little bit, but so then we have to worry about ventilation, perfusion. These patients are high risk for clotting. High risk for clotting. We've initiated a clotting cascade, and we're going to talk about that here in a little bit. Initially, they're low PaO2, PaCO2, but when they fail, just think respiratory active. Remember we talked about that extensively when I talked to you guys about respiratory, and I'm like, initially, most patients go into respiratory alkalosis because they're compensated. But then when that CO2 builds up and they no longer can provide their own gas exchange, always think acidosis, always think acidosis. All right, so blood cultures, okay? Wound culture, so this is like, you know, if something's draining, it doesn't matter, culture it, we don't know. But what are the most common sites? Urinary tract, right? Respiratory, wound, okay? And then if not, stool. They have like diarrhea or something like that, right? So number one, we culture. If I start my antimicrobials before I culture, then I'm masking or I'm hiding the bug that I'm trying to treat, right? So we want to culture as much as we can before we start. Now, if you think your patient has a respiratory infection and they can't cough up a loogie for you, you're not gonna be like, I know that your heart rate's like 150 and your temperature is 102 and your blood pressure is 80/40, but I'm not giving you antibiotics until you can get up that loogie, right? I mean, but if we do a chest x-ray and we can see the pulmonary infiltrates and it looks like they have a pneumatic process, then we would start our antimicrobials. But if we can, always culture first. That's the first thing you do when you're worried about infection and sepsis. Start your antibiotics, okay? Somebody tell me what the procalcitonin. It is, but what are we looking for if we're looking at procalcitonin levels? It tells us if the infection's bacterial. If it's versus viral or fungal. If we start to see that procalcitonin level correct, then we start decreasing the amount of antibiotics. We're treating it, we're fixing the problem. And then nutrition is a big deal. In sepsis, nutrition is a big deal. Nobody comes in with sepsis or septic shock and is like better a day later, right? Like they're on antimicrobials for weeks sometimes. So we need to make sure that we get them nutritional support to help them heal, whatever their cause is. Okay, so this is our sepsis campaign bundle that we use, yes. A what? Oh, I can't remember. I wouldn't ask you that. I really can't. Sorry. Okay. So if we're concerned about sepsis, lactic acid is one of the, like, out of all of the types of sepsis we have, I think lactic acid correlates with septic shock the most. It correlates with septic shock the most. Blood cultures before we start antibiotics, broad spectrum antibiotic within 1 hour. So what do you think is a broad spectrum antibiotic? What do you guys see a lot on the units? Zosyn. You have a lot of, pardon? Doxy. So what does it mean if it's broad spectrum? It treats what? Gram negative and gram positive. I see a lot of cephalosporins. Remember, the further you get down in your generation, so like Rocephin, you guys are seeing that. Further down you get into your like first generation, second, the further you get down, the more gram negative you are. So I see a lot of those because they're not super expensive. There's not a high rate of allergies with them. So broad spectrum antibiotic within 1 hour. And then we give a ton of fluid. So in your mind, so see this, I'm not gonna ask you this question. See this 30 milliliters per kilogram fluid bolus for hypotension or lactic acid level greater than 4. Remember I said greater than 4 is the number to know for lactic acid when we're thinking about shock, including CHF and dialysis patients. We don't care. If they're in septic shock, they have to have fluid. Write this down, 3 liters. If you're initially treating somebody in septic shock, walk in there with 3 liters. What kind of fluid are we giving? Normal saline. We need isotonic, right? Why? The blood vessels are wide open. The cardiac output's down. I don't want to give a hypotonic fluid. What's going to happen? It's going to seep right out of the blood vessels. That doesn't help them, right? So we need isotonic. Just think 3 liters. I don't care if they're dialysis. I could take it off. I could dialyze them. I could diurese them, but I got to give the fluid because remember, everything's leaking out of the vascular space. So we're intravascularly dry and our blood vessels are wide open. Okay. If we need to give more fluid, remember that passive leg raise challenge Dr. Comer talked about, right? So we can give another little bolus and see if we need to give more fluid. I mean, I've given liter after liter after liter. You guys know in the ER when these people come in there, they start running it, right? Okay. This is a screening tool. If you guys are, does any, yes. Uh-huh. Okay. Mm-hmm.
Is that common? Like is the passive leg raise challenge test like not super
So did the patient, were we measuring the stroke volume?
Yeah, they had
An icon? Uh-huh. Was there any change in the stroke volume at all? Because remember, we want that 10%.
There wasn't that we noticed.
Okay.
Like they kept doing it, and then they were like, just shut off an icon, and the patients responding appropriately. The icon wasn't responding.
Oh, so do they think it was the machine?
No, they thought it was.
So I guess let me ask you this, only because I'm an inquiring mind. How do they know the patient was responding?
The patient's blood pressure and like who that is.
So the blood pressure was going up.
Blood pressure was, yeah.
But the stroke volume was not? Because they go together. I'm not saying you're wrong. I'm just asking, like, that makes me think the machine wasn't working. Like,
no, not that I'm aware of.
Yeah.
Residents that they were like walking through it. It's like, that's weird. I'm just gonna shut this off.
okay, so maybe there was something with the machine. Because it would be something that I can't even think of a time where I've seen where we would give a fluid and the systolic blood pressure would go up, the MAP would go up, but we wouldn't see any change in the stroke volume, right? Because they kind of go together. Does that make sense? So like, that's probably why they just shut the machine off, because they probably saw the blood pressure going up, the MAP would go up. And if we're not seeing any other of those changes, maybe there was something with the machine.
Yeah, it was like the patient was physically responsive.
Yeah.
The assessment, but then the machine was saying that they effectively
Weren't doing it. Yeah.
So
I mean,
really,
without being there, that would be my best guess. But again,
yeah, it was surprising.
Yeah. Okay.
I didn't know if that was a common.
No, it's extremely rare. Yeah, extremely rare. Okay. So here's our sepsis screening tool. When you guys are in Epic, does anything ever pop up that says a screening evaluation needs done on your patient? So do you see that in your like documentation or as a student? Like when you're working? Yeah. Yes. Yeah. So you guys probably don't see, that's what I'm asking. You probably don't see it as a student, but what happens is the computer is programmed to use this sepsis screening tool, and it'll automatically, anybody that should be thinking about sepsis, learn to be the nurse, any type of person that's providing care to that patient, it will pop up. And one of the options is to be like, this is out of my jurisdiction or whatever. But it'll say like, what are you doing about this? Like, we're worried about sepsis on this patient. So even the computer will trigger you with sepsis because it is such a big deal, especially in the ICU. But this is a screening tool that they'll use. So a lot of these patients, remember 50% of patients that go into ARDS, right, in the ICU, it's related to infection or an external source. So if we're treating ARDS because of sepsis, or they've had a bad pneumonia, or gosh, all the COVID patients that we've had, we lower the tidal volume. You guys remember that? ARDS, the lungs are stiff, so we can't give as much volume. We lower the tidal volume. We put them in 30 to 45 degrees, head of the bed, and then prone. If the PF, and what is the PF ratio less than 100? It's really bad. It's severe ARDS, right? You guys remember that severe ARDS. Daily sedation vacations, that's not new. Glucose control, that's not new. We've got to remember our DVT prophylaxis. And we talk about that on clinical all the time. Are we given heparin? Are we given, or do we have SCBs on? Are we given Lebanon? How many of you guys have given Lebanon? Everybody, every day, right? Are we giving it? Stress ulcer prophylaxis. How many people are giving Protonics? Right? We had a lot of Pepsid at St. Joe's this week. Somebody giving a lot of Pepsid? I don't like it. I don't like it as much. Remember, the PPIs are stronger. And Pepsid, one of the side effects is thrombocytopenia. You have to really be careful about that. That was Bailey in our patient. I was like, why is this guy on an H2 blocker and a proton pump inhibitor? I'm like, we're not giving the Pepsid because the platelets were 64. Pardon? You gave it? Yeah, it was weird. So it must have been a provider preference. We had a lot of Pepsid at St. Joe's this week. And then if we have a patient on vasopressors, if they don't have an A line, they need to have vitals every 15 minutes. Okay. But ideally, we should have some kind of continuous blood pressure monitoring system. We should have an A line. Oh, that's my hand. Okay. EKG, we're looking at CBC with this. Of course, we're looking at our cells. We're looking at our white blood cell count. We're looking at our platelets. Amylase, we're looking to see if this is pancreatic in nature. Remember, pancreatitis is a big component to ARDS. So if we're looking at amylase, we're looking at the pancreas. We're looking at our cortisol level because that tells us that response. ABGs, we're looking to see for acidotic, BMP or your electrolytes, lipase, that goes along with your pancreas. We should be thinking about perfusion. So we should be thinking, because pancreatitis, you guys remember pancreatitis, like a 122 thing, can cause major infections. Patients can become sepsis from pancreatitis and they can go into full-blown respiratory failure. It's one of the #1 things. Culturing everything and looking at our PTINR because we're looking at our clotting factors. NG tube, either so we could provide suction so they don't aspirate, or we could feed them. And because of the inflammatory cascade, a lot of times we do steroids. Okay. Because of the inflammatory cascades, a lot of times we do steroids, anti-inflammatory. How many of you guys are giving Solucortef in the ICU? Right? We're giving a lot. Let's not give them an infection, right? So let's prevent them. Like, change your gloves. If you wipe their butt, then change their gloves before you give an IV med, right? I mean, it's common sense, but you know, sometimes when you're in isolation, you're like thinking about all these things, and then you have your instructor that's like, "Why are you giving that med? How fast are we gonna give it?" Blah, blah, blah. You're like, "Oh, change your gloves." Right? I don't know. So don't forget that. You know what I mean? Like, you know, think about all those little things, they matter. Okay, so looking at something. Okay. So there you go. Inflammatory response, sepsis, severe sepsis, and septic shock. So we have time to figure this out, right? But how many people are in the ICU in septic shock? Even though we have all this, it's the most common shock we take care of. And we have all this time to try to fix this. But sometimes we have a hard time finding the bug and treating the right bug, you know? Okay, get your concept map. Okay, so especially in sepsis, but if we don't fix the problem, we're going to go into multi-organ dysfunction syndrome, or MODS. Okay, that's what they were talking about, that kid with your patient because of her liver failure. So 2 or more organ systems. Okay, so remember when we talked about liver failure and we're like, if they don't have had a renal failure, that's not good, because now we're in the MODS. We've got 2 organ systems failing. We heard them talk about cardiorenal syndrome. So maybe the heart failure is causing the kidneys to fail. Okay. Okay, I'm not going to go through all of these, so I'm not going to just read off this slide. Okay. However, let me just point out a few things. If you have gastrointestinal dysfunction, what's wrong with your patient? Well, they might not be able to go to the bathroom. They might have an ileum. Like, so just think about the organ system, right? They might have nausea, vomiting. Okay. They might have GI bleeding. If it's a liver problem, they're going to be jaundice. They might have hepatomegaly. The ALT and the AST are going to be up. They might be yellow. The bilirubin is going to be up, right? We have to worry about our clotting factors. Okay. If it's respiratory, we've got a gas exchange problem. The chest x-ray is going to look crappy. We have to think about pulmonary embolism and them going into respiratory failure. Kidney dysfunction. How do you know they're in renal failure? Urinary output, BUN and creatinine, GFR, right? Yes. Mm-hmm. So, and guess what happened to most of those patients? They didn't make it. So once you get into mods, once you're in mods, the chance of survival is less than 50%. So almost every single COVID patient that was in respiratory failure, that it went to full-blown renal failure, once they were on a vent, they didn't make it. That's why the nurses are all dealing with it, like healthcare providers in general are dealing with this post-traumatic stress disorder, because that's all they did. They'd intubate, give all these treatments, and then they'd like either team the patient or it would be a withdrawal of care. And I remember being there, and I haven't seen her that much this unit, but she's like, oh my God, I just want to Hail Mary. I just want to see that one thing that we're doing is going to help. Because it was, but once you get into that, and it doesn't have to be COVID related, it's just, we saw so much of that this past year. But once you get into 2 organ system failures, less than 50% of those patients survive. It's really, really hard. Okay, cardiovascular, right? Our cardiac output's going to be down. We're going to be tachycardic, hypotensive. We're going to start to see dysrhythmias, right? We'll start to see dysrhythmias. Hemodynamics, you're going to have your cardiac output index. Hematological, we're going to talk about this DIC, but we're going to see thrombocytopenia, DIC, and then any of these patients are high risk for an inflammatory immune response. Okay. So DIC, usually we see this with sepsis or septic shock. Okay. And the pit, has anybody ever taken care of somebody in DIC? Well, that's tough. I hate it. I'm good. They clot and bleed at the same time. So when you have sepsis and you initiate this inflammatory immunological response, okay, your body starts to send cells to try to fight off the infection, including platelets and your clotting factor like fibrinogen, because we're like, oh my gosh, something's going on, right? So we start this inflammatory cascade and this clotting cascade, right? So what happens is the body starts to clot, and it uses up all of its clotting factor. The fibrinogen is gone. Fibrinogen is gone. So then guess what happens? They bleed because we've used up all of our clotting factor. Bad prognosis. Bad prognosis. So if your patient's bleeding, what do they look like? Well, they just got to look at every orifice, and you got to look at your hemodynamic parameters, right? They can be hypotensive, tachycardic. Are they bleeding out of the mouth? Look at your lady, like, right? She had, so they didn't know really what it was from. And I wasn't sure if it was like, her lady was yellow, like your highlighter yellow. Like, I bet you she's not going to make it. I hate to say that, but oh God, she looked really, really bad. She had, like moisture built up in her in the ventilator and in her oral. It was like yellow. It was like a bilirubin type appearance to it. And then she was bleeding she was bleeding because of her liver failure, of course, because she wasn't making clotting factor, but was bleeding. Was just bleeding. This is the lady I was telling you guys about that they found down. So we're looking for changes in level of consciousness. If we're bleeding, we have to look at petechiae on the skin. Do we have hematuria, hemoptysis? Looking for all of those clinical, the visual signs. And then of course, think about your hypotension and tachycardia. But if your patient is bleeding, okay, so let's think about this. Let's just go on this pathway with you. Okay, so your clotting factor is fibrinogen, right? So you use up your fibrinogen. So if I drew a fibrinogen level in somebody that's in DIC, what's it going to be? Well, okay. When you use up fibrinogen, the end product of fibrinogen, when you use it and break it down, are your fibrin split products, or your fibrin degradation. You guys remember this from hematology? So you use up fibrinogen, which is your clotting factor, okay? So the end result of that is your fibrin split products and your fibrin degradation products. So what happens to those? They go up or down? They go up, right? Because I've used up fibrinogen, which is now low. My fibrin split products and my fibrin degradation products go up, okay? So now I'm bleeding. So what's my PTINR? High, PTT. High, platelets. Low, right? That's DIC. That is DIC. Okay. Okay, okay. So we've got to prevent DIC and recognize these clinical bleeding signs and symptoms as soon as possible. If my patient's bleeding and they're tachycardic and hypotensive, then I've got to give fluid. I've got to give vasopressors. I've got to give inotropes to bring the blood pressure back up. And we want to slow the use of clotting factor. So we can give fibrinogen. If the fibrinogen is less than 100, we can give this precipitate. We can give platelets. I will tell you though, I've had patients in DIC and we've given platelets, and guess what happens to them? They eat them up real fast. Like, gone. I'm like, oh God, I just gave those platelets, and like 2 hours later, they have no platelets again. And they like literally chew them up. So it's kind of like, we give them, but I don't know if it helps really. We give fresh frozen plasma, which has almost all of the clotting factors, right? So we can give some fresh frozen plasma. Here's the funny, tricky thing. We give heparin. Right? And she's like, what? They're bleeding. Why are we giving heparin? Well, if you look at the clotting cascade and the way clotting happens, heparin blocks the use of fibrinogen. So when you give heparin, it blocks us using fibrinogen. So even though I'm giving heparin, which is going to make my PTT higher, and it's going to make the patient higher risk for bleeding, it stops us from using fibrinogen. So then what happens? I have got fibrinogen left to actually clot. Like another oxymoron. So it's controversial. Sometimes they use it, sometimes they don't. But most of these patients don't think they have anyways. So sometimes we get to that point, like we have to try it, right? Because if we see that we're going down a path where this what we're already doing, giving the platelets, giving the FFP, giving the cryo isn't working, and we say, okay, let's use some heparin. And I've seen it work. I've seen it work. But let me tell you, when I have a patient in DIC and I'm going in to start a heparin drip, I'm like, because I'm like, I already know my patient's bleeding, right? So I'm thinking, oh my gosh, is it going to help or not? It's going to make the bleeding worse, or is it going to stop? So how do you know your patient's better? How do you know that your patient's better? Oh, let's go up. How else? PTI or PTT go down. You're missing the most specific indicator. Go ahead. The fibrinogen goes up. That's how you know your treatment's working. Because we don't have fibrinogen. That's why we're bleeding. We've used it all. So when I start to see that my fibrinogen goes up, that's how I know that it's working. You'll see your fibrin split products and your degradation products go down because I'm not using up all the fibrinogen. It's the most specific indicator that we're fixing it. The fibrinogen goes up. And then to the naked eye, of course, the blood pressure is stable or it doesn't go down anymore. The heart rate comes back down. Cardiac output's okay. We're making urine. We don't have as much blood in the urine. We don't have as much blood, you know, all those things. But this comes, like, you're not gonna be like, oh, that loogie has a little bit less blood than the one I pulled out of them before. I mean, that's great, but it's not necessarily as specific as me looking at those lab values for this, you know, that's gonna be one. Okay. The FFP, platelets, cryo, antithrombin 3, heparin, IV fluids, inotropes if you need to. There's your priority problems. Okay. So if we talk about MODS, we have to find the cause or the initial organ system failure, treat it, maintain perfusion, tissue oxygenation, nutrition and metabolic support. Okay, so give oxygen when we need it, provide ventilatory support when we need it, provide hemodynamic support when we need it, right? That treats perfusion, oxygen and fluid. And then we add our drugs if we need to. So vasoactive drugs if we need to, right? Lactic acidosis, sometimes we'll do those like every 6 hours. Anybody doing that in SIC? Lactic acids like every 6 or 12? Like I see them do it a lot in SIC. I don't see us do it as much, and we do lactics like kind of around the clock at St. Joe's, but I see them do it a lot in SIC. They're like lab happy there. They're like, oh, we're doing sodium Q4. We're doing this, you know, like they do a lot of like cyclical labs. If our patients are really, really sick, we can paralyze them. You know, if we put them on, and this is just standard ICU care. You guys have seen this all already, right? If your patient's intubated, has anybody had anybody intubated? They're like, ah, they're on no drugs. They're super calm. How many of you guys have seen that?
I've had some people that were like, no paralytics or.
So were they awake and alert? Okay.
Well, actually, one was.
Yeah. Yeah.
Yeah.
So those are the patients that are either doing well and we're getting ready to take them off, or it might be like a Guillain-Barré patient that is mentally intact.
I was so uncomfortable with it.
You're like,
Trying to talk and can't.
I know, it's terrible. But majority of the time, if we have our patients intubated, they're sedated. Okay. And just like with ours, remember we would have to paralyze them so they wouldn't fight the ventilator. Same thing with these patients. Like if they're in septic shock and we have then we've got to make sure that we like take good care of them.
But in septic shock, DIC and mod kind of like much better.
So you could have, yes, kind of. So let me put it this way.
Kind of like in a
Yes.
line.
So
Okay.
you could have septic shock and not have mods and not have DIC. But you're not going to go into DIC unless you're in septic shock. That makes sense. You're not going to go into mods unless you're in some type of shock. So it could be cardiovascular shock, you know, like maybe you have like cardiovascular shock and then your cardiac output's so low. Now you're in kidney failure too. So now you're in mods because of that. But you're in some type of shock that would cause mods. And for you to be in DIC, you're in some type of shock, usually septic. But you could have septic shock and we could fix it and reverse it before we get through that progressive phase and they not get to DIC or mods. Does that make sense? Okay. Okay, so how many people were in SIC and they're like, no clothes, please? Like you got like a little towel over the hips. The rooms are ice cold, right? We do that for the brain, but if these patients are febrile, then we've got to make sure, because the higher the temp, the more the metabolic demand is. So we need to make sure we decrease the temperature in the room. We can provide cooling blankets, antipyretics if we need to. We give them a pain medication, right? If we're sedating them and they're intubated, then we've got to make sure we treat their pain controls if they're in pain. If we paralyze them because they're fighting the ventilator or they're so sick, we want to take away all metabolic demands and do all the care. We have to make sure they're sedated. We have to make sure they're on a ventilator. So your adrenergic drugs, these are your sympathetic nervous system. So alpha, beta, beta. We already talked about all of these, right? How well do you guys feel like you know alpha, beta, beta? We good? We don't need to go through and read it again, right? We're good on alpha, beta, beta? Sure. Does anybody have questions about alpha, beta, beta? I feel like I talked the crap out of them the whole semester. So by the time we get to this point, you're like, we're good. I got it.
All of those are all adrenergic, not just alpha.
Correct. Okay. So you guys should know these meds very well already. You've done drug cards on them. You've given them in the ICU. Okay. So beta 1, so butamine, and remember it's an agonist, it's not an antagonist, right? So it's going to cause contractility of the myocardium, increases cardiac output by positive inotropic effects. Okay. Dopamine, same thing. Here's I think this is interesting with dopamine, and especially those of you guys that have been with me at St. Joe's. Dopamine in low doses, we use it to improve perfusion by dilatation. So a lot of times we use low doses to like perfuse the kidneys a little bit better. And then higher infusion, we use it for cardiac contractility. So it's like inotropic. And then the very, very high doses of it, it's used for vasoconstriction. Isn't that kind of crazy? So like dosing matters in this drug, really, really. I mean, dosing matters in every drug, but the use for why we dose and dosing and usage is interesting. Epinephrine, you guys know this, alpha, beta, beta, right? Okay, so it's going to help breathing, it's going to bronchodilate, it's going to increase contractility and heart rate, and it's going to cause vasoconstriction. Norepinephrine, beta 1 and alpha, right? No stimulation to beta 2, you guys see that? It's why we don't use it in anaphylactic shock, because the airway will shut off. But write this down. This is the #1 vasopressive drug used in the ICU across the nation. Leave a fed or leave them dead. So unless your person's in anaphylactic shock, or is allergic to Levophed and they need a vasopressor, this is our first line of choice. First line of choice. We may give neosynephrine instead of Levophed. Why would we do that? So yeah, it doesn't. So neo only works on alpha. So it's going to vasoconstrict, but it's not going to cause that heart rate to go up, right? Let's see. We can use this neos. If you guys look at like some of your over-the-counter like nasal sprays and decongestants, okay, we use this a lot for other things, but if we're giving an IV, it's for treatment of shock. It's a arterial agonist. Okay. Let's see. Alpha. This just talks about the things that I've talked about all semester. I don't want to read off of it, but like these are some of the side effects that you may see if you're giving an alpha. Sorry. If I might give like an alpha aggregator drug. Okay, so these patients might be a little bit have palpitations. They might have a headache or restlessness. There's nothing extremely exciting off of here other than it's going to bring up the blood pressure. Beta. It's going to increase the heart rate. So if you think about Levophed, it's going to make the heart rate go up. It's going to cause fluctuations in blood pressure. And some patients fluctuate very, very quickly. Have any of you guys been titrating Levophed in the ICU? Yeah. Yeah. So we were drawing, we only had one line. We were drawing blood out of the line. So we have to pause your IV fluid. So I was like, Mike, we got to be ready because we got to have everything ready because as soon as we pause our IVs, which we had Levophed running, did we have vasopressin running to that day? I can't remember. Okay. So we had 2 vasoactive drugs, right? Helping to keep the blood pressure up. And we had to pause them for 2 minutes before we could draw the blood. But then whatever time it took to draw the blood. So I'm like, Mike, ready? Like we were like this. I'm like, pause. I'm like, 60, 59, 58, you know, we drew it and then you restart the drugs right away. So I said, you even have to think about what line you're drawing it out of because after you draw the blood and then you're going to flush the line, I don't care. I could go ahead and restart my other drugs. So you don't want to draw like out of line. So we like left those lines running, pause. Our pressure went from like, what did our mount drop to?
From like 85 to below 60.
Yeah, 85 to below 60 in 2 minutes. Right. So you have to be, some patients are super sensitive to that. And then even Bailey, we were titrating, we took vasopressin off of our patient on Tuesday and they were weaning down the Levophed and all of a sudden the patient crashed. So then we titrate up. So we went up 2, 2, 2. We got up like 6 micrograms a minute. And now the patient's MAP was 90. They went from like 50 to 90 in like 30 minutes. So very sensitive. You have to be super, this is why we should monitor the blood pressure continuously and at least check it every 15 minutes. Levophed by protocol usually can be titrated every 5 minutes. You give it, wait 5 minutes, adjust the dose. Wait 5 minutes, adjust the dose. Yes.
Why wouldn't they draw from an art line?
The patient didn't have one.
Why wouldn't they straight stick?
This guy, you couldn't. He was so edematous. We tried to draw from, I think, one of the lines. But yeah, we had to draw from the line. Yeah. We just had to time it. I'm like, Mike, start those drips back up. All right. Don't forget, those rules, like if we're using non-cardiac selective beta blockers, if they're non-cardiac selective, you have to worry about the airway, right? So if you're giving a beta blocker like propranolol, Inderal, they're going to shut down the respiratory drive. So for somebody who's asthmatic or COPD, we have to be super careful about giving any type of beta blocker. Don't forget IV administration. If you have a vasoactive drug, this is why these patients need a central line. Like we should not be giving Levophed through a peripheral line. They need a PICC line. They need a triple lumen catheter because look at that glove. Look at that hand. Okay. It causes cellular damage at the site. So if we have to check the IV site often, if like, let's say we start the Levophed because we have to, they're in the ER, we don't have a central line yet. We start the Levophed, we're waiting for the central line and we see that it infiltrates. And immediately you have to give Redditine for epinephrine, norepinephrine, and dopamine. And you actually inject it into the tissue around the site. You inject it to wherever it infiltrated to save the tissue. Okay, because you can't stop the drug. You got to get a new IV site in and get the drug running, right? Patient needs it because they're hypertensive. Let's see. So this is just like, how do you know that they're better? Well, their swelling's not as bad. If they're, vital signs are back to their baseline, their color looks better. Their level of consciousness means we're proving, if we've got a good level of consciousness, we're perfusing the brain. We're making pee, right? Let's see. Vasodilators, okay? So they're going to relax the arterial and or venous smooth muscle or both. So if you give a vasodilator, you're giving it to decrease the SVR, decrease afterload, decrease preload. So nitroglycerin is wonderful because it decreases, that's why we give it all the time in cardiac patients. Because what did I say? If you have a patient that has an MI, right? Myocardial infarction, right? So now I'm not perfusing this heart, okay? Now the heart has failed. So now we're in cardiogenic shock. Well, what happens? My preload goes up because all the fluid and blood is backing up. My afterload is up because that SVR is clamping down and I'm not perfusing my cardiac tissue. So guess what? I give nitro. What does it do? Decreases afterload, decreases preload, and vasodilates those arterioles to perfuse that cardiac tissue. Beautiful drug in cardiac patients. Beautiful. Nitroprusside, we use this to reduce afterload, usually in hypertensive crisis. I see us use this sometimes in stroke patients that have extreme hypertension afterwards, or cardiovascular patients. But remember what happens in most shock patients. The cardiac output is low. So you would not be giving a vasodilator. You're only giving vasodilators to fix that hypertensive crisis or to reduce afterload in that cardiac shock patient when they're hemodynamically stable, okay? Other thing you have to think about, this is a big deal with nitroprusside. It's like a state board question. They can end up with this cyanide toxicity or this thiocyanate level. They can go to metabolic acidosis. We must monitor that level. We must monitor it if they're on nitroprusside. Very important.
You need to know the level.
You don't need to know the level, but you need to know that that goes with that drug. Okay. These patients have headaches, right? They vasodilate. Think about a migraine, right? When Mrs. Phillips is talking about migraines, what happens? The blood is like rushing to the brain, like boom, boom. You give nitroglycerin, you're doing the same thing to that patient. They have terrible headaches. So in these patients, we can give them Tylenol. You can't stop the nitro, right? The heart trumps everything except the brain, right? So you can't stop the nitro, but you can give acetaminophen for the headache, right? So it's going to cause headache. They might have flushing. We should be checking if they're on a nitroglycerin drip, we should be checking in nitroprusside. We should be checking our blood pressure frequently. Nitroprusside, they should have an arterial line. Nitroprusside, they should have an arterial line. The other thing you have to think about with Tridol is you have to use specific tubing because the tubing will absorb the medication. So if you use our standard IV tubing, the soft tubing, the rubber absorbs it. So we have to use the hard Tridol tubing so that the medication is not absorbed into the tube. Okay, let's do the case study real quick. And then lunch should be here soon. Okay. All right. All right. So this sounds like me lecturing, right? You guys read it and it's like ejected from the vehicle, unresponsive at the scene. I'm like, this sounds just like the patients I talk about, right? All right. So this trauma patient, nurse thing prioritization power, evaluate the information in the case and determine the top 3 priority concerns or cues. What are we worried about? Airway management, number 1, always. Airway, what comes next? Breathing, that goes with airway management. What comes next? Circulation, and what else? Go to my brain. Glasgow coma scale or loss of consciousness, right? This person was unresponsive at the scene. Very important, right? All right. Based on the priority concerns, what action should the nurse perform first as Gerald arrives to the emergency room department. What are we looking at first? O2 set. Absolutely. Airways first, right? Airway, breathing, circulation. We had to tube this guy up the seat. Okay, so indicate if the client's condition is improving or declining. So temperature, better or no? We don't know, right? We're going to continue to monitor it, right? What about your pulse? Worse. What are you worried about? I'm worried about decreased perfusion, but the heart rate went up, didn't it?
Yeah, I meant like if it eventually stops, because it can't be that long, but I wrong about that.
So I want you to think that if you start to become tachycardic, that first responder is activated, right? So beta 1 is activated. Now I'm tachycardic. I'm compensating for something. So if they go from a heart rate of 90 to 104 to 1, whatever it is, 14. Okay, ooh, that's not good. Why are we up? We're responding to something. What about the respiratory rate? Worse, same thing. Now I'm breathing faster. So do I have a gas exchange problem? Do I have a perfusion problem? Am I anxious? Am I in pain? What's going on? But it's not good that the respiratory rate's going up, right? What about our oxygen status? Okay, respiratory decline, same thing. I'm worried. Why do I not have a good gas exchange, right? And then your blood pressure declining. What are we worried about? I'm worried about perfusion. Absolutely. I'm worried about shock. Absolutely. If the condition's worsening. All right. So the nurse completes an assessment on Gerald. For each assessment finding, list why it is concerning. So we're going to start here and just go around the room. Babe.
Are we on 4?
Yeah. Blood glucose.
I thought he has diabetes, so we need to keep it controlled.
Yep. It's out of control. And we know that the higher the blood sugar is, the more stress response the patient's providing, and the high risk for infection, and the metabolism's out of control. Michael, number 2, arousable, does not follow commands.
I'm sorry, I was having
That's okay, I'll come back to you.
no,
So,
I'm good. What
okay.
number are we on? I just got it open.
We're on number 4.
So I said he had a change in LOC, so possible TBI.
Okay, so he's arousable, which is good, right? He wasn't initially, right? He didn't have an altered level. He's arousable, but is he following commands? No, so that does make me concerned. He was unresponsive at the scene, so we don't know if he has a traumatic brain injury. I'm thinking traumatic brain injury, or am I thinking, is this a hypoxia, right? Or am I not perfusing because of our decreased cardiac output or decreased blood pressure? So I'm thinking in my mind, is this a traumatic brain injury and I have increased flowing in the brain, or is this a perfusion problem, right? It could be. It could be. Usually, patients will become a little bit more unresponsive with hypoglycemia before hyperglycemia, but his sugar is pretty high. He was like 5 something, I think, right? So he's pretty high. So he could be going into DKA. Yeah, yeah. Okay, Dahlia, long sounds, crackles bilaterally. What are you thinking? Okay, so maybe if this is, depending on what type of shock, do we have a backup of blood or fluid in the lungs? So I think crackles, I think a fluid overload. What else can it be? Pleural effusion, pneumo, right? He was ejected from the vehicle. So does he have a pneumothorax or rib fractures? He also has a history of smoking, right? So, and COPD, so maybe it could just be like a baseline for him. We don't know, but I'm thinking ahead. Is this a pneumothorax? Did I drop a lung? Is this fluid backing up because because I have a perfusion or a cardiac output issue, right? Okay. Leah, respiratory rate. Yep. So I think what would be the cause? So, okay. Trying to compensate. So we've got a gas exchange problem, right? So is this because of a pneumothorax still? The rib fractures? Is it the fluid? What's going on? But we have that. Okay, I'm sorry. I skipped blood pressure. Amber. Good. Okay. So what are you thinking we got to do right away? Fluids, first line, right? Bolus him. I don't care if he's got heart failure. I don't care if he's got COPD. We got to get fluids right away. Let's try to get that blood volume back up. And then what about that deformed extremity? Nikki? Yeah. So it could be the possible reason of his bleeding, right? He could have a compartment syndrome. Do you guys remember that? Mrs. Phillips is going to talk about compartment syndrome when she talks about burns, because fluid leaks out of the cell so quickly. When we think about burns, we have to worry about compartment syndrome, right? Because all that fluid could leak out of those damaged cells. And then if it stays underneath that skin and traps, now it actually becomes a tourniquet to that extremity. I am more important than Chick-fil-A. No, I see everyone like watching us.
We better hurry this case study up.
I know. But not if I'm going to pull questions from it. Do you guys want to go through it? Okay. So Gerald's blood glucose on arrival to the intensive care unit is 520. What rate will the nurse start the regular insulin drip? 8. Absolutely 8. And that's because of the protocol. Okay. So then let's go to number 5. Okay, 6. All right. So we're just going to go around here too. Jordan, I'm going to come back to you because we skipped over you. So the nurse obtains additional information, documents in the chart, determines if the findings are related to this trauma situation. So the cardiac rhythm, sinus tachycardia with premature ventricular contractions. Do you think it's related or not? Okay, I'm coming back to you. Olivia. Related. Why do you think it is? Okay, so our cardiac output's low, right? They're tachycardic. Electrolytes might be off. So remember, if we talk about potassium, if your potassium's low, you can have PVCs or preventricular contractions, right? Okay, good. Jay, hyperglycemia. You think it's related? Oh, I'm sorry, Jake. You already answered. Quit taking all the answers. Delation. Yeah, absolutely. So any person that's diabetic has it, we don't know when he ate or drank last or took his medicine. We don't know why his blood sugar is elevated. It could be part of the reason that he was in an accident. But now that we've got all this going on, this is definitely a stress response, right? Okay, Kai, what about the respiratory acidosis? It's related. Why? Because of his breathing. So remember, if he's not taking those deep breaths, if we're already hypoxic, we're worried about a chest trauma or chest injury, we have to be thinking respiratory acidosis. We don't have good gas exchange. Paul, cold, clammy skin. It is related. Why? Perfusion. Cold, clammy skin means we're not perfusing. Yeah, absolutely. So it's shock related. Marina, you're an output of 15. Yeah, why? Perfusion again. Look at, we can send this guy into mods if we don't fix him right away, right? Look at all the organ system problems we are having because of this. How about jaundice? Okay, so you could go both ways on this. It could be related because of perfusion. However, typically, if it's a perfusion thing, we won't see the jaundice right away. It'll take a couple days to show up. So if it said ALT or AST elevated, then I'd say, yeah, for sure. But I do think about like the hemolytic, like clotting response. And I do think that can shut the liver down quickly. So it could be related to that. So I would say more in that case that we would need to find a little bit more information to find out if he has any underlying alcohol conditions or something like that to be for sure. Okay, we're gonna come back over here. Sarah Lynn, how about a weak pulse in the right foot? Yeah, because we don't know what happened in that trauma. So we might have this compartment syndrome, it might be a perfusion. Okay, so let's do some thin thinking. So Leah, I'm gonna have you do T. Oh, I said Leah, I'm sorry. Lacey.
So respiratory acidosis, decreased tissue perfusion, hemorrhage, and low potassium.
Okay. The other thing, I'm always going to throw it in there is neuro. We still don't know if this guy has a traumatic brain injury or not. So neurological impairment, because even if we fix respiratory and all that stuff, if they're neurologically repaired, we might lose that autonomic nervous system response, right? Okay, Nicole, H.
Administer O2, administer fluid and blood.
Okay. So change airway conflict. Good. I. Good. Good.
I always struggle with this, but I put out fluid volume deficit.
Okay, so respiratory failure, hypovolemic shock, compartment syndrome, and hypokalemia are the big things that we're worried about in this patient. Yep. And then, go ahead, Tori.
Assess neurological status, Mr. Blood, give them some potassium.
Okay. What about breathing? So think ABCs. What do we do for breathing? So we gave some oxygen, but do we need to put him on a ventilator? Yeah, if he's not on one already, so we need ventilatory support. What about our betas? Right? So we've got a compressed airway. We might need our beta agonist to help with breathing. So don't forget your bronchodilators, suction if we need to. Okay. Bernie, I'm coming to you next. So based on the admission assessment and related information provided, what hypothesis can the nurse make? Yeah, indicate possible shock. Good. Okay. So we'll just keep coming. I'm going to come back up here, TJ. Explain presenting symptoms that support the need for each of the prescriptions. Then describe why the prescription is indicated. So an electrolyte replacement protocol. Okay. Okay. And why is a 3.2 important? Right. Heart changes. So I always think heart first, right? Do we have ectopy or, do we have causes? Okay, we're going to come down the road to you girls. So MAP less than 65, systolic blood pressure less than 90. Taylor, you can take that one.
So for the normal saline?
Yeah.
Is that okay? So that to replace volume, to get volume back.
Yep. So normal saline is going to stay right in that vascular space. Good. How about the blood transfusion?
So his presenting symptoms, low hemoglobin, and then why it's needed to increase volume.
Increase volume. Good. Caitlin, norepi.
For the hypertension, decrease level of consciousness, so we're going to increase the perfusion and get the cardiac output up.
Good.
It's 56.
Good. Good. Mackenzie, insulin drip.
He was hyperglycemic, so this helps return the blood glucose to the normal appropriate levels.
Good. Kara, stat ABGs.
He had crackles in the low SpO2, so you want to see if he's like acidotic.
Good. We expect him to be in acidotic state. So a lot of times these patients are in respiratory acidosis because of the respiratory compromise. But if this turns into a metabolic problem and we start to shut down those kidneys, we're also going to have a metabolic acidosis as well. So we should be thinking that. Okay, Brady, insertion of a triple lumen catheter.
Or from the full replacement.
Good. I didn't hear
Everything he needs with the.
Yeah, so we already just said, I showed you that picture, right? We shouldn't be giving vasoactive drugs to a peripheral site, so we need it for that if we're giving rapid volume. But then here's the other thing. If we put in a triple lumen catheter up here in the chest, what other measurement can I get? CVP, absolutely. Now I can get my preload. So now I can tell if that volume's helping, right? So now I can get a CVP off of that triple lumen catheter. So I love that.
Or if you can just connect that to your phone here.
Oh, what?
Like, is there a cord that you can, or like, how do you?
You would have to, so you remember Dr. Colmer setting up the pressure tubing and that special tubing?
Okay.
that- Yes, but then you would take that, you would hook it up with the pressure set that she showed you guys, and that would get hooked to the triple lumen catheter, but then the other cord from that pressure set would get hooked to the monitor so we can read the CVP up there. Yeah. Okay, what number are we on? Okay. Okay, number 10. So the nurse reviews material for the norepinephrine order. Highlight the critical information in the reference that the nurse should consider with the administration of norepinephrine. Record the nurse's decision regarding administering the medication. Bailey, we're going to come back to you. And skip it. Oh, I skipped Heather. I'm sorry. Go, Heather.
Number 10?
Yeah.
Okay. I put down using the CBC catheter to do extravasation. Then the other consideration was that it was incompatible with insulin R.
Yeah, that's perfect. We should never run insulin with anything else. We have to be super careful about giving insulin. Because if you start to bolus something through a line that the insulin's piggybacked with, what are you going to do? You're bolusing them with insulin and can make them hypoglycemic, right? So we have to be super careful. So compatibility, and insulin should run by itself if we can.
And then it was contraindicated in hypoxia and hypotension. The blood volume deficit.
Okay. Okay, so we got to fix the volume first. Absolutely. Okay, now Bailey, I'm coming back up to you. So number 11, nurse think prioritization power, evaluate the information, select the top 3 priority concerns or causes.
I put worsen respiratory acidosis, loss of blood and electrolytes, and high white blood cells, temperature, so infection.
Okay. So you guys are all gonna fail. If somebody doesn't say level of consciousness, I'm gonna scream. So I'm not just saying that to you, Bailey, because everybody is like, okay, I'm gonna. So you're right. Airway breathing and circulation always go first. Always go first. We're no good without oxygen, right? We're no good if we can't perfuse our organs. But in this gentleman, I'm still worried about this level of consciousness because he's not responding neurologically. And you guys all know now that if you have a traumatic brain injury and you have a change in level of consciousness, that brain is going to give way. What if this patient herniates and we have a major shift in herniation? He's incompatible with life. So let's not forget to go back and check our neuro status on our patients too. Okay. Let's see. How many more do we have? Okay. So let's go to number 12. Type in cross-match blood are available for transfusions. Put in order the steps for administering a blood transfusion. Michael, I'm sorry.
I'm gonna go with 2, 4, 3, 1, 5.
Two.
2 and 4 might be.
So 4 is start the blood transfusion.
No, 4 is identified.
Oh, I see. Okay, so
There's identify the client and do the vital signs. I mean,
Yes.
There's something that's gonna happen concurrently.
those are. So if you put either one of those first, it's okay. You're going to identify your patient. You're going to obtain your vital signs before you start anything else.
ATI asks questions like that. Sometimes you miss them because
I know.
they're two things that are totally interchangeable.
So they are. So I always think about checking vital signs first, because the very last thing you want to do before you start the transfusion is check the identification. So like, think about if we go and give a med pass and we're going to give like metoprolol. I'm like, okay, go check the blood pressure. I'll go pull the med. And then when I come in there, what do? We identify the patient and we scan the med and give it. So think about the same thing with the blood transfusion. I would say check the vital signs. But if you put that you're going to check the patient and then do the vital signs, like you're right. There's so many times we're doing them at the same time. I have a seat in the room, somebody's checking the vital signs, somebody's checking. But I want you to think, if that helps you with boards, I want you to think of it that way. You're going to check your vital signs, but immediately before you provide the treatment, you should be checking the ID band. That's when you should do it. So if that helps you remember that, think about a med pass. Like we don't check their ID and then check the blood pressure. We check the blood pressure, check the ID, give the med. Yeah, there is. Although Bailey, how fast did we get that blood running on that lady? We were like, ding, 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 check, ding, ding, check, or that guy, because he was like he wasn't doing good. So, but yeah, I know you do have, because you have to check the bag to the patient, to the label, to the computer. Yeah. Okay, so the very last thing you'll do is start the blood transfusion. You'll start the blood transfusion. You're going to monitor for signs and symptoms of a transfusion reaction, like anaphylactic shock that we talked about today. And then right before you give it, you're going to prime the blood. You're not going to spike the blood until you verified your patient's vitals and you verified that it's the correct blood for the patient, right? Okay. Jordan, as the nurse compares Gerald's current arterial blood gases and respiratory assessment with the one from admission, what changes could be anticipated in the ventilator settings? Select all that apply. Okay. Two answers or number 2? Okay, so tell me what your answers are. Okay, so I'm going to come back to you for the next one. Leah, what'd you get for 13? Okay. Okay. And maybe increasing the PEEP. So if we've got a gas exchange problem, we have to increase the PEEP because that promotes better alveoli for gas exchange. If we're in respiratory acidosis and we increase the rate, we're going to blow off that CO2. And if we reduce the tidal volume, remember, if we're thinking about our patients going into ARDS, we don't want to give a high volume, right? Okay. The nurse is responding to a high pressure alarm sound on the ventilator. What are the possible causes of high pressure alarms? Select all the apply. Jordan, I'm going to come back to you on this one.
I said,
1, 3, and 5. Good. Lungs are infiltrated. The client is biting on the ET tube. The client has mucus in their way. Do you guys remember that? Right? This is a review for finals, right? So think about things that would cause a high pressure alarm. Something's clogging the tube. The ventilator can't give the breath versus a low pressure alarm. I forget whose room I was in, but I kept knocking the ventilator off the patient. Then I was like, bing, bing, bing. I'm like, damn it. But it was a low pressure alarm. It was dinging because I kept, and so it was all the ventilator support was going into atmospheric air instead of into the patient. Okay, good. Number 15, Gerald's wife asked the nurse why he's on life support. What is the nurse's best response? Go ahead, Dahlia. Yeah, to help support his breathing effort. Good. Number 16, Amber, this will come back to you. What finding in the updated assessment made Gerald at risk for bleeding? Select all that apply. So platelet level, right? That's your first one. Okay, 75, good. 2, potassium level. I don't know potassium to increase the risk of bleeding, but I definitely would agree with the PTINR. But no, vitamin K. Yeah, vitamin K causes clotting, but we're talking about risk for bleeding anyway. So even if that said vitamin K, I would think of vitamin K would be fixing the bleeding, not causing it. Yeah. Yes. Yes. Yeah. You have to think about the clotting has to do with calcium. Yep. Absolutely. Okay. Oh my God. What the heck did I do when I stapled this? Okay, that's all I have. I would bring the last page of this. If somebody wants to give me this, I can. Or you guys want to be done? She's like, okay.
Send
Let
us
me.
out an answer key.
Pardon?
You can send us out an answer key.
Oh, I will. Do you guys get the one over break? Because I know Mrs. Phillips felt bad she forgot to go over with you, but I wanted to make sure to kind of throw that.
If you could give us that. would be great. Outside.
I don't know.